Welcome to the next installment of Critical Care Survivor Guide. This time we're going to be talking about ARDS, or the Acute Respiratory Distress Syndrome. ARDS is defined in 4 ways. The first is bilateral infiltrates on the chest x-ray, as shown here. The second way we define ARDS is by looking at the PaO2 to FiO2 ratio. This ratio tells us how severe the disease is. If the ratio is between 200 and 300, we have mild ARDS. Between 100 and 200 is moderate ARDS, and anything less than 100 is defined as severe ARDS. The third criteria we look for in diagnosing this syndrome is a lack of heart failure. That means that there is a low pulmonary capillary wedge pressure less than 18, or a low central venous pressure less than 8, or a low BNP. It's also acceptable to use standard clinical criteria such as clinical exam and imaging to help to rule out left heart failure as the cause of the bilateral infiltrates. The fourth criteria for ARDS is that we need a reason for it. This might be secondary to pancreatitis, or more commonly secondary to septicemia. The list of causes of ARDS is shown here. Our approach to the patient with ARDS consists of maintaining low tidal volume ventilation. This is extremely important. Good studies have shown that if we provide too high a tidal volume or too high a pressure into the chest of a patient with ARDS, we'll make the disease worse. So we follow these ARDS-NET guidelines. They include starting ventilation at low tidal volumes, that being 6 milliliters per kilogram predicted body weight. The way we ventilate patients with ARDS is based on their height, not on their weight. It's important to recognize that we're not going to be setting the tidal volumes based on the patient's weight, but rather we'll need to know their height. Next, we'll use higher PEEPs, positive end expiratory pressure, in order to help oxygenate these patients. PEEP is a mechanism we use to achieve better oxygenation through not only recruiting more alveoli, but also enabling oxygen molecules to stay next to the capillary interface longer inside the alveoli. After we've set up our ventilator properly with ARDS, the next thing we want to pay attention to is fluid status. So long as the patient is not hypotensive, it's appropriate to try therapy with diuretics. We believe that patients ventilate better and oxygenate better when their lungs are dried out, so to speak. So it's okay to use diuretics and follow the central venous pressures in patients that are not hypotensive with ARDS. Finally, patients that have progressed into severe ARDS sometimes require rescue therapies. These come in many different forms. You'll see different forms of rescue therapies at the different hospitals here at Indiana University. For example, at Wishart Hospital, one of our rescue therapies is the oscillator, shown here. Oscillatory ventilation works through very small tidal volumes set at a constant pressure inside the patient's chest. Additionally, at Wishart and the other hospitals, we have rotoprone therapy. A rotoprone is a special type of bed that turns the patient onto their stomachs. This works to achieve better VQ matching and improve oxygenation. At Methodist Hospital, we have inhaled nitric oxide. That improves blood flow to the oxygenated alveoli. And finally, at Methodist Hospital specifically, we have ECMO therapy, which, as you'll learn about, is a rescue therapy using a gas exchange membrane external to the patient. Sometimes we use ECMO to bridge patients to lung transplant. Other times we use it to help them survive ARDS. So in conclusion, ARDS is a common syndrome that you're going to see in the intensive care unit. It typically involves 4 things to make the diagnosis: bilateral infiltrates, a low PaO2 to FiO2 ratio, a lack of heart failure, and a good reason. It's important that we manage their ventilator properly, consider diuretic therapy, and know when to employ rescue therapies. From the beginning, or?
Whatever you want.
Welcome to the next installment of Critical Care Survivor Guide.
Again, please. Sorry.
Don't get me laughing.
Okay.